Alright, our last little segment. We're going to talk about vascular problems, and then we're going to end back with ischemic heart disease, or looking at heart problems that occur that are outside the classification of congestive heart failure. So my intention is break them up like that so you don't get them mixed up. You know, put too much cardiac stuff together, it's easy for it to blur together. But we're going to break it up with vascular problems, or arteriosclerosis. So arteriosclerosis is a word that refers to hardening, literally translates as vessel hardening. Okay, sclerosis is a hardening type of terminology. So a hardening of the vessels, or a disease of the vessel, as it might be. So if we look at what's going on here, first we got to start out with what the vessel normally looks like. So the vessel itself, in cross section, is in the upper right. And so what you can appreciate is the blood flow. So this is, pretend this is a circle. And this is just one little slice through a component of the blood vessel wall. So the lining that touches the blood is known as the tunica intima. And that's the endothelial lining that we've talked about in this class even. And then there's a layer deep to that that's sandwiched in between what we call the internal elastic lamina, which is this blue dotted line, and the external elastic lamina. In between that is a layer of smooth muscle cells that consist of the tunica media. And then outside of that layer is the adventitia, or the tunica adventitia. And this is a wrapping around the blood vessel. And in the large vessels like the aorta, like we drew up here, it actually has its own blood supply. Because it's such a thick layer of tissue, it actually has to have its own nutrition. And so that's why you see these vascular elements in the tunica adventitia. So things that are happening within the medial or the luminal flow, mean arterial pressure is experiencing, or the vessel wall is experiencing the result of that pressure head. And there are things that can cause damage to this tunica intima, because that's a single cell layer that serves as an antithrombogenic lining. It also serves to provide vasodilatory activity, or for the vessel to go through action of vasodilation where it gets larger. And it's a quiescent layer. Quiescent means it doesn't divide, it doesn't have a lot of activity. And if it's nicked, or if it's damaged, if there's a breach of that tunica intima, then the middle layer, the smooth muscle cells, will migrate into that region, and they proliferate like crazy. And as the smooth muscle cells migrate into that layer and proliferate, they're not supposed to do that. And so that's part of the disease state that leads to the narrowing from the inside of the vessel. Because as this layer proliferates, it makes the hole of the lumen smaller and smaller. So you can see in this lower picture, here's our blue dotted line of our internal elastic lamina. And you're not supposed to have any muscle cells on the other side of that layer. So if you look up here, you can see the internal elastic lamina is right at the base of the membrane where the endothelium sit. And in this picture, you can see that these smooth muscle cells have migrated in here. They've thickened, they've divided and proliferated, and they're laying down extracellular matrix that's not supposed to be there. And as they thicken and they thicken, so this is early disease progression on the right, larger or later disease progression on the right, early disease progression on the left. And as you go here, you get a thicker and thicker intima, and that's called neointimal thickening. And these smooth muscle cells that move into the area, not only do they release extracellular matrix, but they don't have any contractile capabilities because they're behaving abnormally. They're not acting like normal medial smooth muscle cells. So this is what's at the heart of the problem. And we'll talk about all sorts of things that cause damage here, but you can probably list at least one of them because we talked about it. If you have a higher pressure in the blood flow, that is being seen by the endothelium. And it's like they're being pushed up against, and that can cause a breach. Okay. So if we think more about arteriosclerosis, this is a hardening of the vessels resulting in abnormal thickening, like we just talked about mechanistically. The intima itself is what is thickening, and then it causes a narrowing of the lumen. The lumen is the opening of the blood vessel that blood flows between. Now we have two subtypes of arteriosclerosis. And I want you to be familiar with the two different types. Be careful on the exam with the spellings. Okay, that's a hint. So make sure you see what I'm asking. And I know you're going to go, oh, it's so tricky, right? It kind of makes a difference, right? Back in 201, right? In 201, we would nail you in lab for right versus left. Like, oh man, I knew it was the ulna. Give me a break. You know, right versus left. If you're an orthopedic surgeon and you operate on the wrong ulna, that's a problem, dude. Okay, so these subtle differences make a big deal. So I want, it's kind of forewarning, kind of a hint. I want you to pay attention on the exam. So if we look at the first type of arteriosclerosis, it's spelled arteriolosclerosis. So I'm exaggerating L in the middle. Arteriolosclerosis. So this is associated with hypertension and tends to target small vessels, small arteries and arterioles. So it's more of a microvasculature problem. And then the atherosclerosis, which is abbreviated AS, this leads to an atheroma. And the atheroma, or the atherosclerosis, is the one that we're most familiar with. That's the one that gets all the press, because it forms this really disgusting, gross atheroma, lesion. This is the most common type of arteriosclerosis, and it's the one that involves the atheroma, and so it gets the most amount of attention. Okay? The word atheroma literally translates to gruel. And the gruel that you see is made up of all sorts of components. So here's our blue dotted line. This is our internal elastic lamina, which is supposed to be the division above this, or into the luminal side, is supposed to be a thin layer of endothelium. That's the endothelium right out there. And all of this thickening isn't supposed to be there. And abluminally, or to the other direction of the lumen, is the tunica media that's supposed to be where the smooth muscle cells reside. And this artist is trying to use colors to show you these smooth muscle cells are lighter pink, these ones are more red. They're more mitotically active, they don't contract. They are a different subpopulation than your native smooth muscle cells. Okay? And the atheroma, or the gruel, is this structure inside here. And you can see some things that would make sense. This is a disease state. This is a lesion. There's inflammation, right? It's wound healing. It's wounding of the blood vessel, and now it's trying to heal. And it's healing not in a functional way. It's not healing where it's restoring function or returning from a regenerative procedure. It's actually in contrast to that. It's like when you see scarring, whether that's in the kidney or the liver or it's in the skin. And so that's kind of a big concept that we've talked about throughout the entire semester. Regeneration, returning function, versus repair or healing, where you get a scarring. There is definitely scarring is taking place here. So we're getting a fibrous cap that surrounds it. Inside of this fibrous cap, we've got macrophages. Those macrophages gobble up different types of lipids and cholesterol that's residing within that luminal surface. and they become what's called foam cells. Foam cells are macrophages that have phagocytosed fats or lipids or cholesterol. And that's these blue cells with the little yellow dots. The yellow dots are indicating that it's now a foam cell. And you can see here's a macrophage that's being recruited, but hasn't ingested any lipid yet. This is a monocyte. And because this gets so thick, and it doesn't have a vascular supply, remember I told you the tunica adventitia is thick enough that it needs its own vascular supply. This layer is thick enough that it needs one but doesn't have one. And so you get a necrotic center in the middle because it's not getting enough blood flow. It's too far away from the blood supply because it gets so thick. The diffusion distance of oxygen in normal healthy tissue is about 250 to 300 microns. And this is definitely not healthy tissue. So the diffusion distance may only be 100 or 150 microns. And so if you can't get oxygen diffused across into that center of that lesion, then it goes necrotic. Okay? So this is the two different types of arteriosclerosis. Atherosclerosis with an atheroma being the most common. So how does the AS form, or the atherosclerosis? Well, there's multiple steps, and in summary, it's a chronic, ongoing inflammatory response, which shouldn't be a surprise. I promised you at the beginning of the semester, when we first met, that we'd have inflammation peppered throughout the entire semester. And we would talk about it again at the end, and that's what we're doing. Ongoing inflammatory response to chronic injury. What's the chronic injury, we say? Well, the chronic injury, we said one could be elevated afterload or an increase in mean arterial pressure, otherwise known as hypertension. So you can see up here, chronic endothelial injury in air quotes, and the injury could be like hypertension. That's the second one on the list. Notice some of the other ones. Smoking, hyperlipidemia, too much lipid in the blood. If there's high lipid levels in the blood is more viscous. It doesn't flow nice and smoothly. And so as it flows more aggressively, it can cause traumatic injury to the endothelium. So you don't want hyperlipidemia. You don't want blood that's got too many lipids in it. You don't want high cholesterol, right? We're always looking at HDL versus LDL levels in our patients. What's the difference? HDL, or the good cholesterol, is the one that actually brings lipid back to, and cholesterol back to the liver. And LDL is one that brings it out of the liver into the circulation so that it's bioavailable. Why would it need to be bioavailable? Well, you need lipid and cholesterol when you're trying to repair cells, when you're trying to make cells. So when you're young and you're growing, right, in adolescence, you might have LDL levels that are okay to be a little bit higher than in you and I. Because now we've stopped growing, we just need to maintain the cells that die. We're not making new ones. We're not growing, 6 inches a year and making new tissue. I'm not sure I ever grew 6 inches in a year, but you understand what I mean. So repair is all you need, and so you don't need that much LDL. And as we get older, our metabolism decreases, so we need less and less LDL. And so we're always looking at keeping lipid levels and cholesterol levels down. Some other ones that we didn't talk about, that we won't talk about, involve different types of toxins or viruses within the blood, certain types of immune reactions where the endothelium are coming in contact with foreign objects, or hemodynamic factors that are unrelated to hypertension. Okay? But the biggies on the list, really the top three: high fat, too high of blood pressure, and smoking. Those are our biggest culprits. This causes endothelial dysfunction, and as it breaches and causes a lesion, it moves into the tunica media, and now you get this macrophage activation, and you get smooth muscle cell recruitment into a region in the tunica intima where it's not supposed to be. And so as this takes place, we start losing the function of the endothelium. They no longer have an anti-thrombogenic surface, and they no longer are able to respond. The vessel itself no longer can dilate. Right? Partly it can't dilate because now all of a sudden it's diseased and it's stiff. So we get these blood vessels in my lab from cadaver not patients, they're no longer patients. Cadaver donors, that's the word. So cadaver blood vessels come to my lab on a regular basis, and we analyze them. We look at these lesions, okay? And sometimes we'll cut out a segment of the vessel, and we'll use razor blades to do that. And a lot of times, the atherosclerosis is so aggressive that as you cut through it, it's crunchy. It's like, and you look at the blade, and it's jagged now. And you have to put it in the sharps container to get it in. And then if we want to cut up the vessel, right, fillet it open and lay it out so it's like a rectangular piece, so we can do mechanical testing on the inside of the vessel. One pass of the scissors, surgical scissors, and now they're dull. They won't cut paper because it's like cutting through stone. That's how much stiffness results. So they no longer will dilate. They're like a stiff or a non-compliant tube when they're this diseased. All right. So as it progresses and moves on, we start recruiting monocytes into the area. They turn into tissue macrophages. If the macrophages ingest lipid and cholesterol, they become foam cells. If you got macrophages present, then you have these reactive oxygen species that are in the area because of the respiratory burst mechanism. Remember that? Macrophages use this free radical generation in order to destroy or kill bacteria. And it may not be bacteria that's really present. So the reactive oxygen species are not even used. So those free radicals now are available to oxidize stuff. And they oxidize low-density lipoprotein, fat. And as it becomes fat that's oxidized, it kind of sticks in place. Right? Oxidation makes things more like hard and tarnished. Right? Some of you have oxidized hoods on your car. Right? It's out in the sun too long, and now the paint becomes oxidized. And so it doesn't feel smooth anymore. It changes its consistency. That's exactly what happens to these LDLs when they become oxidized in the presence of these free radicals. We already talked about the infiltrate being taken up by the macrophages, the development of foam cells into the area, and you can see the progression as this picture goes from top to bottom. This lesion gets more angry as time goes on. Because there's a lesion on the lumen, you're going to get things sticking to it like platelets. That can actually result in a thrombus or a clot. And if this is happening, it happens all throughout the body, but if it's happening in a coronary circulation or a coronary vessel, then the patient develops a heart attack. If it happens up in the neurovascular elements and the vessels are small enough and there's a clot, then they have a stroke. Okay? The smooth muscle cells are recruited to that area. We talked about the ECM, or the extracellular matrix that they produce. And we talked about the lipid that continues to accumulate. So this is kind of an interesting picture. And this picture is describing kind of in cross-section what things look like. So we've got a normal vessel on the left. Try to get my left and right correct this time. And then we've got progression over on the right. So more aggressive disease on the right. And it's just looking at, and here's our boundary, here's our internal elastic lamina, that's our division, where we should have really nothing close to the lumen, and abluminally, away from the lumen is where all the muscle cells should be. And you can see as this progresses, you get this really angry looking battlefield in the neointima, right? You've got macrophages, monocytes diakinesing. They become tissue macrophages. They uptake lipid. They become foam cells. These foam cells can oxidize fat, LDL that's stuck in this area. And this causes a lesion that becomes hard and stiff and non-compliant. It's at risk of rupturing, especially if the patient is hypertensive, because now it's not going to stretch. It's like an old, worn-out rubber band. Don't you hate when those things fracture on you? They always fracture like smack you, right at the wrong time. So they're unstable. If they rupture, then they become what's called a complicated plaque. Complicated means they present clinical issues. Clinical issues if they rupture. So they're very, very dangerous laying there. They're kind of like a ticking time bomb. If they're a stable plaque, then it's not at risk of rupturing, but it could migrate from a stable plaque to an unstable plaque and then rupture. And if it ruptures, you might have an aneurysm, or you might exsanguinate, bleed out, or you might have a hemorrhage. Now, in that fibrous plaque is a population of C-reactive protein. This is normally found in the blood. It elevates in response to inflammation. And so the other thing that happens within this plaque is you get this collection of C-reactive protein that gets stuck there. And this C-reactive protein can increase the recruitment of macrophages into the area. All right, what do these plaques look like? So on this picture, we've got the panel on the far left. Panel on the far left is the L is in the lumen. The L is showing this white space, and if you were going to circumscribe this whole area, this white space should occupy everything that my laser pointer is tracing. It should actually be this entire area. And you've got all this stuff in the middle of the vessel that doesn't make any sense. What is all that garbage? Well, that's actually part of the atherosclerosis. So this fibrous cap labeled F, so that actually fibrous cap goes all the way around. And this letter C is the lipid core. This is where the lipid core is actually prevalent, right in the middle of this necrotic. So you've got this edge right here that used to be all the way down here, and then there was a breach in the endothelium, and all of this right here thickened and narrowed the blood flow. So we would say in this particular example, this was probably about 60% occluded, or maybe only about 35 to 40% patent. That's the terminology we use. And even in this case, it may not even be recommended for treatment depending upon where it was located, depending upon the age of the patient. So if you look at the blow-up diagram, this is a trichrome stain, and so all of the blue is deposited extracellular matrix or collagen. And so there shouldn't be this much collagen, especially right in the middle of the blood vessel. It's not supposed to be there. This was all deposited by the muscle cells that moved into the area. Panel B is a higher magnification view, and we're looking at a portion of the plaque. And all of the yellow deposits is lipid in this particular stain. And this arrow is pointing to a black squiggly line that outlines. That's the internal elastic lamina. That's that blue dotted line we're looking at. In this particular real example of histology, this is a black squiggly line. And so everything from here in shouldn't be there. Does that make sense? It should be like a one layer thick on top of that black squiggly line, and you have all of this luminal garbage. If you blow up into higher magnification view on the right, and you look at a hematoxylin niacin stain, now we see the calcification demarked by the arrowheads and neovascularization demarked by the arrows. So the arrowheads are pointing to like these big white chunks. You see this whole chunk of mass right here with these white little flecks? That's calcium, like stone, in the middle of the blood vessel. That's what's giving it that crunchy appearance. Okay? And the arrowhead, or the arrows, are pointing to new blood vessels that have grown. And the new blood vessels have to grow because this tissue thickens and it needs a new blood supply. And so that's a response to try to keep it from going necrotic. Okay? Pretty crazy that you have this happening inside of these lesions. But that's what atherosclerosis looks like. Now, if we look at the different types of outcomes, what could happen? Well, we've got a preclinical stage. So I'm going to scare you a little bit. I'm not trying to, frighten you. But this is over a lifetime. So young age, you get into what we call this preclinical phase. And in the preclinical phase, we have the development from a normal artery into some fatty streaks, or some regions that become diseased. Well, that fatty streak can progress into a fibrofatty plaque, and as it moves on, you start getting cell death within the luminal wall. You get plaque growing, you get ECM deposits, you get foam cells forming, and you start getting narrowing of the lumen. You're really, I would argue that this is really at the point where you're now in the clinical phase. So I don't really love this diagram. I would actually draw the line right through here, and I put this advanced vulnerable plaque over in the clinical phase. That would be my addition to the textbook if I was writing it, but they didn't ask me to write it, so I'm just telling you. I really think this is more middle-aged to elderly phases of life, but it all begins somewhere early on. And we've got three different outcomes. Well, if it's vulnerable and it ruptures, you can exsanguinate the blood volume, okay, depending upon the size of the lesion or the vessel. Well, if it occludes by blood clot, right, then you get like in an immediate event where the patient might have a heart attack if it's in the cardiac tissue, or it might have a stroke if it's in neurovascular tissue. Or the third outcome is this just continues to grow and eventually closes off, and you get complete stenosis or closure, and you have no patency any longer. All of these three situations can result and cause ischemic heart disease, and they do. Okay, now there is some good news in today's lecture, right? And that is, how do we treat these things? Well, we've got some therapies that we can look at. The first one that I'm going to talk. Oh man, how do I want to open it? Just open it. Sure. Okay, so I think there's audio. There's some smart sounding person. Smarter than me. Okay. So if it's in the cardiac circulation, right, we're going to look at
Venous coronary intervention, also known as coronary angioplasty, opens narrowed coronary arteries. A small, hollow tube called a catheter is inserted into an artery in the groin or arm and threaded to the affected artery. A thin, flexible metal wire is then advanced through this tube and past the site of blockage in the artery. A second, smaller catheter is then inserted over the wire and threaded to the same artery. When it reaches the narrowed area, a small balloon on its tip is inflated to reopen the artery and flatten the blockage into the artery wall, while at the same time stretching the artery open to increase blood flow to the heart. Both catheters and the wire are then withdrawn. About 70 to 90% of coronary angioplasty includes placement of a stent, a wire mesh tube that holds open weakened arteries. The stent may prevent re-narrowing after an artery is widened, and it stays in place permanently as the blood vessel lining heals over it.
Okay, so ideally, that's what happens, right? So if this is in the coronary circulation, the number of open chest procedures is dropping every year. It's getting less and less. Because more of these procedures are being done through what we call less invasive approaches or endovascular approaches, where we'll access either a vessel from the arm, right? From the arm, you can actually hit the aorta and then get into the coronary circulation almost as a direct shot, the left arm. If you think you can get there from the right arm easily, you need to look at your anatomy textbook again, because the aorta kind of turns this way, right? So it's this arm. So that's where right and left makes a huge difference, right? You look kind of foolish if you're going to go in and do an endovascular approach, and like, all right, prep the arm. Like, prep the left arm. Right? I want left brachial access. Right? Okay. So left arm. The other one is through the femoral arteries in the groin. Okay, so actually, it's a great prep place to take blood pressure because the femoral artery actually or take a person's pulse, but it's a little awkward to be reaching down here. So then we do up here and up here or up here. But right here, the femoral arteries are a large vessel that come within centimeters of the surface of the skin. Okay? You always hear about, like, dogs that fight or whatever, they always go for the neck. I think they even know it's not cool to go for the groin. But they can actually kill the organism or their opponent much easier if they just bit them right here. And they wouldn't see it coming because they're always like battling the neck. But anyways, so you can access it from the femoral arteries or the arm, and you get in, and we place a stent. In some cases with larger vessels, there's a covering over top of the stent. It's called a covered stent. In some cases now, we'll actually impregnate the stent metal with a drug, and those are drug-eluting stents. Why a drug? Well, we'll use a drug that's a inhibitor of proliferation. So we'll use a drug like paclitaxel, which prevents cells from dividing. Why would that be valuable in the interface where that lesion is? Any ideas? You don't have collagen buildup. What cells are producing that collagen? In this case, it's the smooth muscle cells that came from the media, right? The tunica media. So we've got a lot of options, but they all kind of follow that same theme of percutaneous balloon angioplasty. Okay, so this next video is showing, it's not narrated, so I'll have to narrate. And this is a catheter into the coronary circulation. They're injecting contrast agent, and you can see that it didn't go distally. This happens really fast. Here you got the wire, here's the pigtail wire. They see these two marker bands? They're inflating the balloon right between those two dark bands. Then they inject and reestablish blood flow. If you blink, you'll miss it. You guys want me to rewind it? So I'm going to pause it. Hang on, let me get to... Okay, so here they've got a catheter. Here's the end of the catheter. They're injecting contrast agent. It shows up dark. The contrast agent fills these vessels that move this way, a little bit in the background this way. But there's this large vessel that should go all the way down here. And the reason you know it goes all the way down here is here's where their wire is. That's the other end of the wire from that diagram or that cartoon video that we saw. So in a minute here, the interventional cardiologist is going to insert another catheter, and it's going to have two dark marker bands that are separated by a distance, probably about a 3 centimeter distance. Okay, and I'll pause it here in a second. So still injecting. You can see there's no distal flow. Okay, do you see where it is? This is like a Where's Waldo kind of for smart people, right, or for grown-ups. Cardiovascular nerds, more like. So here is the marker band, and here's the other marker band. In between those marker bands is a balloon. And if you watch, they're going to inflate the balloon, and you'll see it get dark in between because it's expanding the lumen, just like the video showed that you watched, the cartoon video. So now he brings it back. He stops right where he thinks the lesion is. Right there, inflates, now injects again, and look, it reestablishes all these vessels that you couldn't see before. Make sense? So that's just balloon angioplasty. That's one of the fastest procedures I've ever seen. Okay, like literally you blink and it's over. Everyone's high-fiving and he's on the golf course, right? So it doesn't always go that simply, and a lot of times they'll leave behind maybe a stent or a stent graft, maybe a drug-eluting stent, but that's how you blow out and open up that lumen. So I want to ask you, what are some concerns? What are some questions that you have about the way that we treat these lesions, just academically?
Is there a way for the angioplastic ballooning to be too strong and actually pop the...
Absolutely. Good question. The question was, is there ever a problem where the balloon inflation is too much and you break the vessel, remember, they're weakened vessels, right? I told you when we analyzed them in my lab, I mean, they're like stiff. So if they don't stretch much, how do you know when's too much? So vessel rupture is a problem, right? And so usually on the device manufacturer's instructions, it'll tell you safe inflation volumes. But, I mean, physiology and biology, doesn't adhere to these nice little tables that the engineers like to make, right? And so in a lot of my work, I'll get these questions by the developing engineers. It's like, well, how many PSI or how many mils of fluid should we put into these patients? Like, well, it depends. Well, I can't write that on the box. You gotta give me an answer. And like, I would prefer a number with a range and then a safety margin. Well, biology doesn't work that way. So you test it in clinical trials to try to dial in what's the safe range, and that's what you put on your packaging. And that's why we do all these clinical trials. Other concerns, can you rupture the vessel? What else? I agree. I'm asking you to think outside the box a little bit. What are some other questions or concerns you have about the way we treat these things? Again.
But you're shoving, with this angioplasty, it's shoving the hardness into the side of the blood.
Sure, yeah, you smash it out of the way. Yeah, we don't care where it goes, it's just not in the way anymore. Is that a problem?
Yes.
Possibly. Does the vessel remodel around it? Yes. Do you think we ever break off little bits and pieces and they go downstream? Yeah. Where do they end up? I don't know. Okay. Interventionalist is on the golf course at that point. If they end up in the brain, it could cause a stroke. If they end up into the other heart portions of the heart, it could cause a heart attack. They could go into the feet, cause an embolism, make it back to the lungs, cause a PE, a pulmonary embolism. All sorts of problems that could happen. Paclitaxel, it's an anti-proliferative agent. Stops cells from dividing. What's the 20 years from now, what's the long-term impact of putting drugs on the inner lining of a blood vessel? Well, we don't know. We're just doing it, man. Okay? So they're not perfect, and that's why there's so many iterations in this space. I just wanted to show you kind of two very basic examples of what this looks like. Okay? Our last topic is back on the heart. Okay? But it's relevant because as it relates to ischemic heart disease, you have to appreciate what's happening to the blood vessels. And so the blood vessels that we're talking about are going through this atherosclerotic lesion development. And that's happening in the coronary circulation in the heart. So another biggie that we deal with, congestive heart failure, atherosclerosis, and then ischemic heart disease as it relates to cardiovascular problems. Okay? And these are much bigger than like valve abnormalities or valve problems. And that's why I honed in on these three for today's lecture. So in ischemic heart disease, we've got an imbalance. We have a problem. We have a demand and a supply that's off. And so the perfusion is the supply. And then the demand is the metabolism of the heart itself. It has its own metabolic requirement. And if that's off, then you negatively impact the ability for the heart to work. And if the heart doesn't work as well, then you lose its ability for cardiac output. So another formula of how to get cardiac output is you take the heart rate times the ejection fraction. An ejection fraction, or EF, is a value that means, okay, if I fill the blood with 6 liters of blood per minute, how much per minute stays in the heart? Or you could look at ejection fraction on a cycle-by-cycle basis. So if I have X number of milliliters that fill the heart at any one given time, let's pretend it's 300 milliliters at any one given time. What percent of that 300 milliliters remains in the heart itself after it ejects? So I'm going to ask you a question. You should know the answer to this from 202, but let's just see what you think. Because the heart is a pump. So we talk about pumps and we talk about output, we talk about efficiency. So ejection fraction is what percent? Do you think half? That would be a 50% ejection fraction. So if you fill it with 300 milliliters, only 150 come out every beat. That doesn't seem very efficient, does it to you? No. In fact, 40% or less is the definition of an EF where the patient is now considered to be in heart failure. Make sense? So 40% or lower, the patient's in heart failure. So it's not 40%, it's not 50%. What do you think is normal for you and I? Assuming that we're quote-unquote healthy. Any guesses?
Maybe 80 or 90%?
I would love it to be that high. 80 is getting close. It's about 75 to 85 is the range of an EF for normal healthy patients. You'd never really see 90%. That might be like some athletic freak. That would be cool. I don't know. Maybe Michael Phelps. Someone should measure him. Okay, they've measured him. I'm sure they've measured him, but they never published on EFs. But maybe they never published on EFs because like the normal population wouldn't care. They're like, I don't know what that means. 90%. I'm probably 95. So I don't know why they haven't looked at it, but that would be crazy awesome if he was that high. I don't know. So cardiac output, heart rate times ejection fraction. So if the heart works less efficiently as EFs drop, because you're not perfusing it with enough blood flow for it to work as a pump, you're going to influence its ability to work efficiently as a pump. And then that compromises cardiac output. So atherosclerosis is one of the most common causes of this imbalance between perfusion and the demand that the heart needs. What happens when you have ischemic heart disease? The heart's not getting enough blood, the vessels are narrowing, it's not getting to where it needs to go in the heart itself, not in the body, we're talking about the heart itself. So now we get chest pain, angina pectoris. That's a pain. It's really a strangling feeling in the chest. That's what it translates to, angina. Acute myocardial infarction, where you've got a heart attack, an acute MI. The heart just stops working. You can have chronic ischemic heart disease, where over a long period of time the heart becomes ischemic, or you could actually just have sudden cardiac death. So if we look at angina, it's translated to a strangling feeling in the chest, or chest pain. We've got a couple of types that I want to describe. So angina pectoris is intermittent pain due to myocardial ischemia, a strangling feeling in the chest, or heart pain, angina. Stable angina is there's pain when the patient exerts energy. So like when they go upstairs, climbing a flight of stairs, or when they exercise, on a treadmill, at the gym, New Year resolutions coming around, they decide I'm getting in shape, okay? And then they have chest pain on the treadmill. So that's stable angina, and it's only when they exert themselves. Prinz metal, or another word for it is variable angina. This is usually pain during resting times at night. May have vasospasms that are associated with it. Unstable angina, otherwise known as crescendo angina. Crescendo, for those of you that are musically inclined, what does that mean? Crescendo versus decrescendo. What's that? Gets bigger or gets louder over time? Crescendo. So crescendo angina is over a 3 to 4 day period of time, it increases. So they have chest pain on Friday, by Monday morning they're in excruciating pain. That would be crescendo. There's usually a plaque that's been disrupted, and there's thrombus associated with crescendo. It's getting worse as days progress. They often have pain at rest, and it leads to a myocardial infarction. So a way that you might see this on the exam, these definitions, which type of angina occurs as a result of vasospasms of one or more coronary arteries. It happens often when the patient's sleeping. We've got unstable, stable, silent, or Prinz metal. D is correct. So what does this look like if we evaluate how an acute myocardial infarction takes place? Well, it migrates, there's like a wavefront. Okay, so here we've got a much better drawing than my drawing. So maybe, is there anybody that drew something like this? I just am always curious if you got one of these. You got one of these? You guys have like skills. That's amazing. And like mine's a box. Some of you are like Cupid, you know, aww, right? And then others, you know, some of you have the like heart shape. I'm not even gonna try to draw one because I wouldn't be able to draw it. I could do this, right? And then some of you have these art skills. Okay, so here's what we drew. You can see the circulation of the heart. We've got our left circumflex, and we've got our left anterior descending, LAD. And then over on the right side, we got our right coronary. Then we have some on the back side, the posterior aspect, we're just showing the front. Here you can see right down here, the left anterior descending, otherwise known as the LAD. There's this little blockage right here. You guys see that? Right where my pointer is? And the area at risk is in this dotted line on the apex of the tip. That's the zone that's at risk because it's not going to get distal blood flow. And the ischemia that takes place when you block that, the myocytes can last about 20 minutes without blood and then they start to die. And so transit time, paramedic time, getting to the OR or the cath lab quickly, from when it really closes off to when you're going to have scarring, you only have about 20 minutes. Okay, so if you see an ambulance with the lights on, like, get out of the way. That's like, that's my biggest pet peeve. If there ever was road rage that I'm guilty of, it would be at that moment. I usually pull over and just like white knuckle, but these are people, you need to get out of the way because there could be somebody in there with a heart attack. You got 20 minutes and then it's over. So 20 minutes is all we have. And so you can see over here this area that's kind of a lighter shaded pink. This is the area that's going to go necrotic. This is going to be a necrosis that's what type of necrosis? Oh man, you just threw that in there. Like, just, that review question just came at me from nowhere. Coagulative necrosis. Very good. Okay? So it really begins subendocardial on the inside. And as it migrates, here's 0 hour. Here's 2 hours later, the necrosis is on the subendocardial front. And it's going to move over just a 24-hour period. It'll be all the way through. It's called a transmural infarct. Okay? Transmural infarct is a necrotic region that goes all the way through excuse me, the wall of the left ventricle. So if I don't have one, but if I showed a picture of some histology, would you be able to tell me if it was transmural or if it was just subendocardial? You think you could do that based upon everything that you've seen this semester? I bet you do it. I bet you could figure it out. You'd be looking for a lesion or damage or scarring. It doesn't look like the rest of the heart. Excuse me. That went all the way through. All right. Transmural versus subendocardial. So when patients have, I swear I'm not having a heart attack. I just have a tickle in my throat. When patients have a heart attack and there's damage to the heart, we can look for certain markers. We can do labs to determine maybe how old it is. When did it happen? Is it likely that its intervention is going to be able to treat? And so we get these leak proteins that are caused as a result of the damage to the heart. So this is not histology. But what you can see is this gross picture. Yeah, that's disgusting. But gross meaning like large view. Okay, so this is the left ventricle over here, and this is the right ventricle. And in this case, it's the right ventricle that's affected because you kind of tell the normal tissue over here and the normal tissue on the left ventricle, and then you've got the subendocardial lesion that's necrotic. You guys see that? And if you zoom in, it doesn't go all the way through. It's not transmural. So this lighter shade is where the infarct tissue is, and this more purple is sort of the normal healthy tissue. But if that was a histology picture, you'd be able to see the difference in the transition zones if it went all the way through or if it was only part way through. Okay? Still enough to kill this patient, obviously. That's how we got the heart. But if you look at blood proteins, we've got different types of leaked proteins that happen from these patients. So troponin, TNI and TNT. So troponin are one of these accessory proteins that are involved, if you recall, they're involved in cross-bridge formation, right? Troponin. And as they're involved in cross-bridge formation, if you have ischemia in an infarct, those contractile actin and myosin cross-bridges, they're very delicate structures. They deteriorate very quickly. And so the troponin leaks out. It's a very sensitive protein structurally, and so it leaks out into the circulation. So you can measure troponin I and troponin T 2 to 4 hours after an infarct in the blood, in a patient's blood work. It peaks at about 48 hours and it remains high for 7 to 10 days, for a week to a week and a half. Creatine kinase myocardial bounce, CKMB, this is along with lactic dehydrogenase, LDH. These are indicators that the heart is actually looking for non-aerobic sources of energy. Why? Because it's not getting blood flow. So if it's not getting blood flow, it's not getting oxygen. And so the heart tries to move to non-aerobic energy production using glycolytic pathways. Well, if you use glycolytic pathways, you're going to steal as many ATPs as you can from creatine kinase. So you get an elevated CKMB in the blood, and you're also going to start making lactic acid. And so you actually have an upregulation of LDH in the blood. So CKMB rises 2 to 4 hours after a heart attack, peaks a day to 2 days after, but it's gone by about 72 hours. So if you don't see CKMB, but you see TNI or TNT, you know the infarct happened longer than 72 hours ago. Make sense? The last one, lactate dehydrogenase. Again, this is an indicator of enzymatic activity associated with glycolysis, and it follows a similar timeline as CKMB. So we have a myocardial infarction. What are some of the complications that can show up as a result of it? Well, number one is we can have arrhythmias, especially if it's targeting or involving any tissue that's associated with the electrical conductivity that's being sent throughout the heart. We have, maybe obviously, contractile dysfunction. We could have a myocardial aneurysm or a rupture. And this in of itself could lead to a mural thrombus, which is what you're seeing right here. You're seeing a rupture with mural thrombus in this picture. And lastly, you could have what we call progressive heart failure. Progressive heart failure could be a surviving patient that has an ischemic episode, an infarction, and that creates an area of the heart that's not working as well. And then that causes sort of this long-term cascade of events where they start developing heart failure. It may begin on the left side or the right side, depending on where the infarct is. And over time, they develop sort of this ischemic heart disease that leads to chronic heart failure or congestive heart failure. Okay, so they're all kind of intimately related. Any questions over the cardiovascular section? Or any questions over the semester in general? So you have my revised office hours for next week. I will be available on email if you have any questions between now and the final. Otherwise, thanks for a great semester, and I will see you next week. Okay?